All right, good morning, everybody. It's a pleasure to see everybody here today. Welcome to our grand rounds as we're rapidly approaching the end of the year. This morning, we are hosting our Jeffery Cleven speakership. Dr. Cleven was an internist with the Portland Clinic for, I understand, 40 years. I didn't actually know him myself, but he was a stalwart and a fixture of the Portland Clinic for many years, and I understand he retired in 2017, and as part of his retirement set up this lectureship, of which our visiting speaker, Dr. Linas, today is the second visiting professor. Dr. Linas is a professor of medicine at the University of Colorado. He is the Rocky Mountain Professor of Renal Research, where he's served as faculty at the University of Colorado throughout his academic career. He's directed the Renal Fellowship Program since 1984 and headed the section of hypertension within the Division of Renal Diseases since 1994. He's also chief of nephrology at Denver Health Medical Center. He has been well involved with the medical school, earning many teaching degrees or teaching awards. Our own Dr. Robert Hudon was a medical student there, and he was telling me what an exciting lecturer Dr. Linas is. We're excited to have him. He was also a treasurer of the Board of Internal Medicine. He's served as editor of multiple nephrology journals, published dozens of articles. And originally this talk was sort of written as update in hypertension, and Dr. Linas has expanded that to an update in nephrology. So we're really excited, and welcome, Dr. Linas. Thank you.
Thanks very much for the introduction. What I'd like to do with you today is first off honor Dr. Cleven. I met him last night. I had dinner last night and during the day, and he really has been a remarkable man in internal medicine in Portland at the Portland Clinic as far as what he brought to a practice and how he developed, and the practice developed over the years. I would hazard a guess there are not many physician-based practices like that left in the United States. I know of a couple, but not many.
Are you turned off?
No. You work on this for a second. Better? Yeah. Better. Sorry, I'm sorry. And kind of would just like to honor him as far as recognize him as far as his contribution to internal medicine and medicine in Portland in general. And so what I would like to do with you today is to talk about some issues that are new and what I've called relevant to nephrology, in particular to the primary care aspects of nephrology, not inpatient subspecialty care, but to your practices as well. As I thought about this, if you're like me, I can't sit through a 45-minute talk on one topic. I lose interest pretty quickly. There's only so much you can say. And so what I've done is I've picked 3 or 4 areas to work off of that I think are the most relevant. I've picked what I feel are the most relevant papers in the last year, and we'll go through them with you at a pretty quick pace. And so going through this, my slides do not do the papers justice. These are very, very high quality studies. In the interest of moving it forward, I've condensed it to 4 or 5 slides. And so there's a lot more data that I'm going to show you. You're welcome to my stick with all of the slides and the references on it. And kind of that'll be the format I use today. And so I do want to start with hypertension and CKD. And the format will be the same. There'll be oftentimes a question, and then I'll show you the study. So this starts as a question. This is a type 2 diabetic with chronic kidney disease and a stable increase in serum creatinine from 1.5 to 1.9 after initiating an ACE inhibitor. The creatinine is stable. It went from 1.5 to 1.9, and it's locked at 1.9. Blood pressure went from 155 over 90 to 142 over 86. All is good. And the question is, what would you do at this point in time? Would you stop the ACE inhibitor? Would you cut back and maybe half the dose of an ACE inhibitor? Or would you bite the bullet and continue with the ACE inhibitor as you're doing. So a little more than a kind of 20-25% increase in creatinine. So how many of you would stop the ACE inhibitor altogether? How many of you would reduce the dose? How many would you bite the bullet and push on? Kind of, most people, that's what we're told. And believe it or not, we've never up until now had data to support that recommendation. And I would hazard a recommendation that we maybe ought to go higher than 30%. And so these are the studies. So the first one is entitled Association of Acute Increases in Serum Plasma Creatinine After Renin-Angiotensin Blockade and Subsequent Outcomes. The format's going to be the same. It's going to be the slide title, the reference, and you'll see as we go through. So the background here is increases in serum creatinine frequently occur after initiation of an ACE or ARB. The cardiovascular and renal outcomes of increases in creatinine are not known. And so this is a retrospective analysis of something known as the Stockholm Creatinine Database, almost 32,000 adults initiating RAS inhibitor therapy, multiple variable Cox regression analysis on cardiovascular or renal outcomes, standard outcomes, and this is what the data looks like. And so the first data slide shows that there are increases in death according to increases in creatinine. So if you look here with me for a second, then this is time in years going across the x-axis, and these are individual 10, 20, or more than a 30% increase in creatinine. And yes, if it's more than a 30% increase in creatinine, it looks like there's an increase in death rate. There are increases in heart failure, but not myocardial infarction according to increases in creatinine. This is the heart failure data. It looks pretty much the same as I showed you before. This is the MI data. It's pretty easy to see no increases in MI. There were also increases in end-stage renal disease according to increases in creatinine. This is the blown up data here. And so again, over 30%, you could see a striking increase in creatinine. And so if you look at like hazard ratios, this is the hazard ratio for a greater than 30% increase in creatinine. And if you go down here, whether you look at mortality, heart failure, et cetera, all the data is on that side of the identity line, i.e. an increase in creatinine of more than 30% is bad for you from a renal and cardiovascular. The investigators concluded that acute increases in serum creatinine after RAS inhibition of greater than 10% were associated with increases in risk of death, heart failure, and ESRD. And so kind of there's some buts here. It's an observational study where those treated with renin blockade, angiotensin blockade, sicker to start. There's no comparison group with intervention. And does this mean that we shouldn't continue RAS inhibition if this creatinine increases by more than 10%? You saw the data that 20, 30% or more. Is this kind of out there saying this 30% number we talked about before is the wrong number? And the answer is no. This is an observational study. Another study, again from this year, looked at increases in serum creatinine after ACE therapy and its effect on clinical outcomes in type 2 diabetes. And so it's going to verify some of the stuff that we just looked at, but it's going to make another very important point from clinical medicine. So the background here, and again, all my slides are going to have this format of a title slide, background, some methods, results, and a conclusion. Creatinine often increases after initiating ACE therapy. The long-term outcome of patients with increases in creatinine after ACE compared to other forms of therapy is not known. Observation, we know it's bad for you, but what about comparison stuff? So the purpose of the advanced study was to determine the outcomes in patients with a wide range of changes in serum creatinine after initiating ACE therapy. Sounds familiar. The advanced was 11,000 diabetics, usual blood pressure management, and the study then is an add-on of perindopril and indapamide, an ACE thiazide-like diuretic versus placebo therapy. There are 4 groups based on creatinine increases, less than 10, less than 20, 20 to 30, and greater than 30, pretty standard. And the primary endpoint is a composite of mortality, cardiovascular events, and renal events. So what we're going to do here is we're going to take a group of diabetics who are pretty well controlled diabetes-wise, and then we're going to put them on an ACE versus placebo, and we're going to look at the outcomes. And the first thing that came was very much like the first study I showed you, that increases in serum creatinine is predictive of badness. And so kind of in all comers, if the creatinine increases by less than 10%, here's the line of identity, 10 to 20, more than 20, more than 30. We've seen this data from the last slide, that an increase in creatinine after an ACE is a predictor. These investigators added a new piece of information. They've looked at hazard ratio. Here's the increase in serum creatinine percent-wise here, and you can see that if the creatinine increases by about 10 or 20%, there's an increase in hazard ratio, 30% in increase in more, but look at the 40% number. They don't have a lot of data at the 50%, but it looks like it levels off at about 30%. And so that's going to come back and be an issue as far as recommendation. Despite increased risk compared to placebo therapy, there's improvement in long-term outcomes. And so compared to placebo therapy in this group, if the creatinine were to increase by greater than 30%, you can see the data all is on this side of the line. The composite data is on this side of the line. And so despite the increase in creatinine, you're better off being on an ACE, in this case, than on placebo therapy. And so the conclusions are, and again, this is diabetes after ACE inhibitor therapy, increases in serum creatinine are associated with higher risk of events, but, and this is the big but, there's a reduced long-term risk of events compared to other forms of therapy. And so bottom line here is if there's an increase in serum creatinine, tolerate a 30% stable increase in creatinine, not a creatinine that's doing one of these numbers, but one that's doing these numbers. And in our practice, we tolerate a 40 or 50% increase in serum creatinine as long as it's stable. So we're not talking about someone who starts with a creatinine of 6 that goes to 9, that's different. But people who start less than 2 and go, say, 1.5 to 2.4, 2.5 or something like that, that's stable, we think is important. Hyperkalemia is often more rate limiting than serum creatinine, and so the cause of decreases in GFR after aggressive antihypertensive therapy is there tubular injury or is it all hemodynamic? Don't have time to show you that study. The bottom line is that it's all hemodynamic. It's not tubular injury. All right, and so kind of next question. In a diabetic proteinuric patient with CKD and a GFR that's greater than 60, still greater than 60, what do you prefer? An ACE inhibitor, ARB, or a combination? So someone pretty standard type 2 diabetic with proteinuria and a decent GFR, how many of you prefer an ACE inhibitor? An ARB, couple. So combination therapy, couple, kind of no real consensus. And so up until now, the dogma has been kind of ACEs and ARBs are pretty much the same. Never, never, never do combination therapy because it's bad for you. That's the dogma, and that's what we would have said. And so there is a very nice study that's known as the LIRICO study, which is a study on the long-term impact of Renin-Angiotensin system inhibition on cardiorenal outcomes. It's a randomized control study. It's going to get to this point. And so the comparative effectiveness and safety of ACEs, ARB, and combos remains unclear. The consensus out there is the combination is bad for you from a safety perspective, not so much an efficacy, but a safety perspective. So this is a multi-center randomized open label blinded endpoint trial. It's big time. It's ACEs, ARBs, or combination therapy to a blood pressure less than 130/80. It's moderate to severe albuminuria and diabetes and other cardiovascular risk It's the type 2 diabetic that you're taking care of in your practice, and the endpoint are the usual cardiovascular events. The enrollment was slow. The study was stopped early, and I'll show you why for a second. They wanted a couple thousand patients. They only got about a ballpark 1,000 patients, a large enough number to make sense out of it. And so here's what the data looks like. The data says there's no difference in the primary endpoint. And so kind of if you look here, that this is ACE, ARB, and combination therapy, it looks like the combo is kind of a little worse than either one alone, but it's not statistically significant over the 4 years of study. There were no differences in renal endpoints using albuminuria and estimated GFR. Now that came as a surprise. If you'd have asked me, I would have said that combo therapy is better for you from an albuminuria and protecting GFR perspective. But you can see in this particular slide, whether you look at albumin excretion or GFR, there really was no difference between the three therapies. The only real difference was in the safety side of it, and the safety signal was, as you would expect, cough. And that, not surprisingly, a larger number of patients on ACE or combo therapy, maybe 15, 16% versus 5 or 6% on ARB, discontinued the medication because of cough. And so that was it. From an efficacy perspective, nothing. From a safety perspective, nothing bad, cough for sure, but in essence, nothing more than that. And so the conclusions were patients tolerate ARBs better than ACEs or combo therapy, but there's no difference in cardiovascular or renal outcomes between ACEs, ARB, or combo therapy, and that whatever you like and whatever the patient like is wonderful. It's very difficult to get on one's high horse that one is better than the other, little less cough. Depending on the cost of the medicine, you might go with one or the other, et cetera. Now, I want to switch off now and deal with another very hot topic this year, and these were the SGLT2 inhibitors and GLP1 receptor agonists in CKD. And so a lot of work in this area in the diabetes field, a lot of work on the cardiovascular side of it, but I want to say what I call nephrocentric for the study I want to show you and the results I want to show you today, because this is new information over the last year. And the study that brought this is called Canagliflozin and Renal Outcomes in Type 2 Diabetes and Nephropathy. And so the key here goes as follows. The SGLT2 inhibitors have been shown to reduce cardiovascular morbidity and mortality in Type 2 diabetes with and without CKD. So in CKD, we know they're cardioprotective. To date, renal events have not been a primary endpoint, especially in patients with pre-existing CKD. So the newness of this Canagliflozin study is the renal endpoint side of it, not the cardiovascular side. We know the think we know the cardiovascular. Until this, we thought, but didn't really know the renal. So the purpose of this was to determine the effects of the SGLT2 inhibitor Canagliflozin on renal outcomes in type 2s with albuminuric CKD, double-blind, randomized, type 2 diabetics with significant albuminuria. It's an SGLT2 inhibitor or placebo on top of everything else. I'll come back to that in a minute. GFRs of 30 to 90, creatinine excretion of 300 to 5,000 milligrams per gram. Everybody was on max dose of a renin-angiotensin inhibitor. So this is on top of RAS inhibition, and the primary endpoint is renal plus cardiovascular. The newness of this study is the renal endpoint. About 58% were on metformin, 65% on insulin. And so the first thing that was very striking, there was hardly any reduction in hemoglobin A1c, 0.25 to 0.3%, statistically significant, but that can't mean anything from a clinical perspective or renal perspective. There was only a 3 millimeter difference in systolic blood pressure. So it looks like coming into this, whatever effect we're going to see of the SGLT2 is not mediated by blood pressure, is not mediated by better diabetes control. It's something nephrocentric, if you will. And so here's the data. If you look at the composite endpoint compared to placebo, canagliflozin was associated with about a 30% reduction in the composite and renal and cardiovascular endpoint, kind of not new information. It's the renal stuff that I'll show you in a second. Here's the cardiovascular stuff, about a 20% reduction in cardiovascular event rates in people with CKD. We've known that. The empagliflozin studies, the dapagliflozin studies have shown us that. It's the kind of renal stuff that we think is important. And so here's a subgroup analysis that says that canagliflozin is effective in patients with decreased GFR and heavy albuminuria. If you look in this red box for a second, here's the GFR data. This is GFR 60 to 90. This is 45 to 60. This is 30 to 45. The drug is effective. Same thing as far as big proteinuria down here or less big proteinuria up here. The drug is very effective from an endpoint perspective. Here's the effect on albumin and eGFR over time. As far as albumin is concerned, about a 30% reduction in albumin excretion. Remember, on top of ACE or ARB inhibition as well. And so this is big time stuff. Here's the GFR data, and I want you to see two parts of the GFR data. Here is the long-term information that shows that canagliflozin preserves GFR rather than placebo therapy. But if you look up here with me for a second, when you initiate the drug, there's always a small decrease in GFR. This is a hemodynamic effect from something called tubuloglomerular feedback or tubuloglomerular balance. In essence, we've seen this with ACE inhibitors. It's almost something that helps us knowing that you're on the right dose of a drug. If you don't see a small decrease in GFR, then probably you need more drug. So the conclusions are type 2 with proteinuric diabetic, proteinuric CKD, canagliflozin decreased the risk of kidney failure and death from cardiovascular disease. This is a game changer from the renal perspective. And again, I'm trying to stay tightly focused on the nephrocentric side of it. This really slows renal progression. This next statement basically is almost heresy. On the grand scheme of things, this makes RAS inhibition look like a piker as far as protection is concerned. This is big time stuff. So it's a game changer on top of ACEs or ARBs. The mechanism probably intrarenal, not just blood pressure or diabetes. There also are some issues that we need to resolve. Only 5% of patients in the study were African American. And so we're also wondering if this drug might be useful in other types of proteinuric renal disease. For example, another big problem for us is something called FSGS, focal segmental glomerulosclerosis. We've got preliminary data that this drug is protective under those circumstances, not ready for prime time. We've also got preliminary data in heart disease that in the absence of diabetes, this drug is protective. This really is a game changer as far as clinical medicine is concerned. All right, and so to move on in this one, from the nephrocentric perspective, are there differences between SGLT2 inhibitors and GLP1 receptor agonists? They're out there as well. The GLP1s are especially effective in diabetes control, weight loss, et cetera, cardiovascular disease, et cetera. Is there evidence of cardiovascular protection, renal progression? Are they the same or different? And so, as luck would have it, there was a large meta-analysis, and this is the meta-analysis that looks at the differences between the GLP receptor agonist and the SGLT2 inhibitors on a number of endpoints. It's a meta-analysis with all the positives and negatives of a meta-analysis. So both have been shown to reduce cardiovascular and renal progression in type 2. The relative benefits of these two classes of drugs in patients with and without, that is secondary prevention and primary prevention of cardiovascular disease, has yet to be established. And so it's a meta-analysis, 8 large trials, 77,000 patients. The study I showed you before, the Creatinine study, was not included in this. This got published at about the same time. The Creatinine study will make the data even go in the same direction we're talking about. So here's what it looks like in summary form. Both classes of drugs reduce major cardiac events in patients with established heart disease. These are people with established heart disease, whether it's GLP1 or whether it's SGLT2, they're all in that direction. It didn't do much as far as primary prevention is concerned. So as far as putting it in the Portland water supply as a primary preventive measure doesn't make sense. If you've had a cardiac event, it really does seem to make sense. The SGLT2s, but not the GLP1s, reduced hospitalizations for heart failure. Here's the heart failure data with the GLP1s. It doesn't look like there's much of a change. Here's the data with the SGLT2s. My sense is the mechanism of that is the SGLT2s are, by causing glycosuria and natriuresis, they volume deplete you a little bit, and that may be the heart failure data. That's an opinion. That's not been proven out yet. The SGLT2s, but not the GLP1s, prevented progression of CKD. And so here's the GLP1 data, and you can see it doesn't look like it's much. Here's the SGLT2 data. I've shown you one study. There are other studies as well out there. And so bottom line is that from a renal perspective, the SGLT2s look like the name of the game. So in trials presented to date, both classes of drugs reduce major cardiac events in patients with established cardiovascular disease. Only the SGLT2s reduce admission for heart failure and slowed progression of CKD. So from the renal world, it's the SGLT2s that we're most excited about, less so the GLP1s. Now I want to show you one other study because this class of drugs is going to come our way pretty soon. And this is a study entitled The Impact of Sotagliflozin on Renal Function, Albuminuria, et cetera, in type 1 diabetes. So everything I've shown you so far, and to my knowledge out there, has been in type 2 diabetes. Now, the SGLT2s have been shown to reduce cardiovascular events and slow progression in patients with type 2 diabetes. No data yet on SGLT2s in type 1 diabetes. And so this sotagliflozin is a dual SGLT1 and SGLT2 inhibitor. Now, a little sidebar. SGLT is in the KID2, is in the kidney in the proximal tubule in association with glucose reabsorption. It mediates sodium reabsorption. SGLT1 is in the kidney, but really not active to any great extent under any circumstances. Its primary purpose is in the gut to mediate glucose reabsorption in the gut with some sodium. This sotagliflozin stuff inhibits both. As you're looking at this, we don't think the SGLT1 has anything to do with anything. And so the fact that it's a dual inhibitor, look beyond that and just look at the SGLT2 stuff. So the purpose here was to determine the effect of this sotagliflozin on cardiovascular and renal markers in type 1 diabetes. That's the newness here, type 1 diabetes. This is a combination that I've put together called the In Tandem 1 and 2 trials. Large number of patients, 1,575 adults. It's a 52-week study, so it's not one of these 4 or 8-week studies. It's placebo versus sotagliflozin in addition to optimized insulin, and the renal and cardiovascular risk factors were the endpoint. So we're looking at risk factors here, not hard endpoints like death, myocardial infarction, and stuff like that. So it's a little earlier on. It's not an outcome study. It's a risk factor study. So here's the effect of sotagliflozin on GFR. And so like what we've seen before, when this drug was started, there's a decrease in GFR. Disappointing, if you look at GFR over time, doesn't look like this drug was especially effective as far as preventing decreases in GFR. And so one aspect in type 1 diabetes doesn't look quite as good. However, as far as protein excretion is concerned, like the other SGLT2s, you can see big decreases in protein excretion. In this study, about 50% reduction in protein excretion. We think that this will ultimately translate into a decrease in progression, renal progression, but it's not there yet. All we have so far is the proteinuria study. Here's the effect on blood pressure, kind of in contrast to some of the other studies, about roughly a 10/4 reduction in blood pressure. That's not small. That's worth one antihypertensive in the treatment of high blood pressure. So this drug looks like it's antihypertensive as well as preventing proteinuria. Small increase in hematocrit. This is hematocrit, not hemoglobin. So a 2% increase in hematocrit probably doesn't mean anything, but it gives you some sense that these drugs are diuretic and natriuretic, contract the intravascular volume just a little bit, and that's what it looks like these does. So the bottom line conclusions were, in type 1, combination SGLT1 and SGLT2 inhibition was associated with the same hemodynamic changes as seen with an SGLT2 in type 2 diabetes, i.e. decreases in blood pressure, protein excretion, and the small changes in GFR. The comments is it was tough to tell how many of these people are already on RAS blockade. We don't know that yet. The eGFR decline may be good, may be bad, kind of we don't know yet. Kind of I think it's fine, I think it's good. I think it tells you that it's an ACE-like hemodynamic effect. We don't know that for sure. This is the first in class in type 1 diabetes, but my bottom line is be really, really careful about this approach because these are the patients who are going to get normal glycemic DKA and get into trouble. And so this is a proof of concept kind of study. It's coming our way, but not ready for prime time. Now I want to switch a little bit again, and I want to talk about what I've called new drugs in nephrology. Most are available, or if not available today, they'll be available in the next several months. All of that kind of is probably true, except for this one. Now, this is one of my favorite studies, and so up front, the pharmaceutical industry and the FDA are not as in love with this as I am, and as many nephrologists are, and let me see if I could show you, but this is something that I think you're going to see in the next month. So it's entitled Inhibition of Interleukin-1 by canakinumab, and cardiovascular outcomes in patients with chronic kidney disease. And so the background here goes as follows, is that inflammation likely contributes to CKD progression as well as accelerated atherosclerosis in CKD. So where we are with this is that most of us feel from a renal perspective that the name of the game in CKD progression is yes, blood pressure, yes, some diabetes issue, but when you pull back on that, there are many, many, many people who progress and get heart disease with well-controlled blood pressure, with well-controlled diabetes. And the working hypothesis is this is a big-time inflammatory state that may be mediated by interleukin-1b. So cardiovascular disease remains the most common cause of death in CKD. There's something known as the CANTOS study, which is canakinumab anti-inflammatory thrombosis outcome study. Not easy to say, but out there. This was looking at canakinumab, which is an antibody inhibiting IL-1B, and so it reduced cardiovascular disease events in patients with a prior history of MI and persistently elevated CRP. And so that study was out there, a New England Journal study, but like many studies, initially CKD patients were excluded. When they went back and looked at the CKD patients, there was some very interesting data that evolved. So the purpose of this study was to determine whether canakinumab reduced cardiovascular event rates and improved renal function. And here it is again, renal function among patients with prior MI and chronic kidney disease. So up front, it's not going to improve renal function. And so this is not going to improve renal function, and that's why kind of the study has not been taken up as much as many of us would like to. These were stable post-MI patients with high C-reactive protein. In this particular study, 2 was defined as high. They're randomly assigned a placebo or dose range of canakinumab, and it's the primary endpoints of cardiovascular and coronary and cardiovascular event rates. So in essence, this is a CKD study that we're going to look at the CKD population, and we'll look at cardiovascular events. And so this first slide makes my point that in CKD, there are issues with inflammation. And so these three bar graphs show you the major cardiovascular event rates in those with GFRs over 60, under 60, kind of cardiovascular death, under 60, all-cause mortality, under 60. And so we know, and you know, that CKD is bad for you. And so how bad? The number that I like to remind people of is that in the United States, we know that there are about 30 million people with CKD. Of those 30 million, roughly 15 million have more advanced CKD. So 15 million, there are about 500,000 people on dialysis. So to go from 15 million to 500,000, patients have died before they make it onto dialysis. The warriors make it to dialysis. Everyone else dies before dialysis. And so that's the name of the game with CKD. Is there something we can do in CKD to kind of prevent cardiovascular disease and slow progression? And so here's the data that shows catechismab reduces cardiovascular events in patients with and without CKD. And so here's the CKD data on this side, about roughly a 30% reduction in cardiovascular event rates. This is all people with GFRs over 60. If anything, it looks like that drug is better in people with lower GFRs than higher GFRs. The drug was most effective in patients with higher CR, or those who they were able to reduce the CRP level. In patients who they were able to reduce it to under 2, you saw a more protection than those that were over 2. So if you could get the inflammatory state under control, it looks like a protective drug. From our perspective, there were no adverse. That's good. There are no protective effects on GFR. So in patients with CKD, cardioprotective, but in contrast to the SGLT2s, not renal protective. So IL-1 inhibition with kind of reduces cardiovascular event rates in high-risk CKD patients. It's especially effective in patients with robust anti-inflammatory responses, and there was no renal protection. So this drug is coming our way from a cardiovascular perspective. We are really very excited about it. From a renal perspective, not because it slows progression like SGLT2s, but because it prevents cardiovascular disease. Now, another class of drugs that we're going to see in the next 6 months are known as the endothelin receptor antagonists. Now, endothelin is much like angiotensin 2, only much more potent. And so much more potent. So endothelin is a protein that binds to a couple receptors. It's vasoconstrictive. It's pro-inflammatory. It's everything that angiotensin is, only much stronger, if you will. And so there now are a number of endothelin receptor antagonists that are about to hit the market. And I just want to show you one study to give you some sense of what it looks like. And this is a study with a drug called atrasentan. There are 4 or 5 others. They all look the same when you look at the data. It's early on, but they're coming your way. So this is a study of atrasentan and renal events in patients with type 2 diabetes and chronic kidney disease. It's double-blind, it's randomized, it's placebo-controlled. It's a Lancet study from several months ago. So the endothelin receptor antagonists have been shown to reduce proteinuria in diabetic and FSGS glomerulopathies in short-term studies. We've seen that over the last couple of years. The long-term effect of these drugs is not known. The purpose of this study was to determine the effect of ETAs on long-term renal outcomes in patients who are responsive to ETAs. So this is going to be a little bit of a different study design. It's double-blind, it's placebo-controlled, randomized. Type 2 diabetics with GFRs of 25 to 75 and 300 to 5,000 milligrams of protein a day. They're on max doses of ACE or ARBs and diuretics. So they're maxed out on ACEs and ARBs. They're treated with 4 weeks of atrasentan at the dose you see, and they identify a group of responders as defined by a 30% reduction in proteinuria, about half of the subjects, and they then are continued on the atrasentan or then switch to placebo. So the study design, a little different. They're going to take people who respond to atrasentan, keep them on or take them off, and see what it does to some of these endpoints. So the endpoint is doubling of creatinine, end-stage renal disease or death. This is a renal study, and so what you can see is that as far as urine albumin excretion is concerned, you can see that at least in this particular study, there was about a 50% reduction in protein excretion. Remember, these are people on ACEs or ARBs maxed out, so this drug is reduces proteinuria, and so there starts out to be a pretty good effect on blood pressure. You know, over time, it doesn't look to me like the major effect of this drug is on controlling blood pressure. There's some reasons from that. We'll come back. It looks like independent of blood pressure that, in fact, this drug is pretty good as far as reducing albumin excretion. Here's the composite endpoint and doubling of serum creatinine of the placebo group, which is in the orange. The atrasentan group was in the blue. And so you can see that there basically is about a 30% slowing of progression when one looks at composite renal endpoint and death with this particular drug in patients who are maxed out on ACE or ARB. They showed you the data in non-responders. Now remember, they cherry-picked the people who responded to the drug. In non-responders through the duration of the study, the atrasentan group looked a little better, but not much. And as far as all subjects, it was kind of statistically significant. But the key here is that in people who respond with a reduction in protein excretion initially, and you continue on the drug, this looks like a very positive study. So from a safety profile, there was a fair bit of edema in both groups. These are people with CKD, so that's not surprising. And so the other thing that was a little unexpected is that there was a increase in anemia in the endothelin receptor group from about 10 to 18%. The definition of anemia was a little bit soft. When you look at some of the other studies, this doesn't look like it's going to be an issue. Kind of my sense is that some of the anemia may be hemodilution because these drugs actually do cause some salt and water retention rather than anything direct. So the conclusions were that atrasentan reduces renal endpoints in type 2 diabetes who are pre-selected for optimized therapy. It's a funny study design that I'm not so sure of. How severe was the anemia fluid retention? But the key is you're going to see this class of drugs in the next 6 months or so. They are going to be initially marketed for perhaps blood pressure control under some circumstances, for slowing progression, proteinuria, et cetera. I think this is going to be a big addition from the renal perspective. I want to skip this one and do one other before I end that I think is big time. And so I want to do this roxadustat study because I think on the scale of things, this is something that's going to be very major as far as our practice is concerned. And so this is entitled roxadustat for anemia in patients with kidney disease not receiving dialysis. So here it is, this CKD theme again. What can we do to slow progression of kidney disease? What can we do to prevent cardiovascular outcomes in people with CKD? A little bit of background. The HIFs are transcription factors that regulate genes in response to hypoxia, including erythropoiesis and iron metabolism. I'll show you a schematic in a minute, but kind of the way these transcription factors work as follows is under normoxic conditions, there are a series of proteases known as the prolyl hydroxylases, which hydroxylate and inactivate HIFs. So normoxic position, HIFs aren't active because they're inactivated by these prolyl hydroxylases. Under hypoxia, the prolyl hydroxylases are inhibited, and so because these drugs are inhibited, HIFs are active. They dimerize, translocate to the nucleus, activate transcription, and cause erythropoiesis. So under hypoxic conditions, HIFs are active, and so under normoxic position, they're not. And this is shown again in schematic form. This is up top, the hypoxic condition, and under the hypoxic condition, then these prolyl hydroxylases are inhibited, so HIF can go to the nucleus, do its thing, and cause erythropoietin transcription. So whether there's hypoxia or a drug which inhibits the prolyl hydroxylase, then HIFs are active and cause kind of erythropoiesis. The other side of these HIFs is something known as hepcidin. Hepcidin decreases iron transport from the intestine and the liver, i.e. and results in decreased red cell production. HIFs inhibit hepcidin. By inhibiting hepcidin, there's increased iron transport and red cell production. And so if, in fact, you are hypoxic or on one of these prolyl hydroxylase inhibitor, HIFs are activated. They decrease hepcidin, increase iron transport and red cell production. So bottom line of all this is something that inhibits the prolyl hydroxylase will activate HIFs and increase erythropoiesis. And so roxadustat is an oral inhibitor of prolyl hydroxylase, first in class to my knowledge. It increases HIFs and erythropoiesis. Earlier studies showed that roxadustat increased erythropoietin levels to near normal levels in CKD and ESRD patients. I want to focus on the CKD patients. Kind of the purpose here was to determine the efficacy and safety of roxadustat in CKD. Also ESRD, but I want to emphasize the CKD. Phase 3 trial, 150 some patients, double blind, roxadustat or placebo for 8 weeks, then 8 weeks of open label roxadustat in all patients. Key here, no iron therapy, no ESA therapy. This is placebo or roxadustat, and the primary endpoint is change in hemoglobin. 75% of these patients had GFRs under 20. This was big time stuff. These weren't people with GFRs of 60 to 80. Their mean hemoglobin to start was about 9. Their mean iron sat was 22% and ferritin was 220. So this is it. These are stage 5 CKD patients about to initiate dialysis. And so here's the data. So the data shows that roxadustat was associated with an increase in hemoglobin of about 1.9 grams per liter. Not a surprise. We had seen that earlier, kind of probably not what got it into the New England Journal. What got it into the New England Journal is shown on this slide. So kind of the big surprise here was roxadustat was associated with decreases in cholesterol and LDL cholesterol, and this was not subtle. And so the cholesterol was down by about 40 milligrams per deciliter, the LDL by about 25 milligrams per deciliter. This is big time stuff in people already on statins, ACE inhibitors, stuff like that. And so I think that's why it got into the New England Journal, not because of the anemia data. If you will, that wasn't expected. It's this cholesterol stuff. And it gets back to my comment before that these patients are dying of cardiovascular disease. Is this another way to look at that? So there were a couple adverse effects, high K and metabolic acidosis. They were statistically significant, but when you look at the data, I don't think meaningful. And so the conclusions were that roxadustat is efficacious in treating anemia in CKD patients. There was an 18-week open label phase where the roxadustat continued to be efficacious. The cholesterol went down more, if anything. Not a primary endpoint, I get it. This was an observation, but that's what makes this so exciting. So I think this one is a potential game changer as well, and especially with regard to lipid metabolism. And so kind of you gotta have some concerns here that these HIFs are ubiquitous, if you will. They do more than erythropoiesis, kind of, it can't be good for you when you mess around with them as much as the roxadustat, we're going to really need to see some long-term study and see where we are. All right, I think I'm going to tie it up and say the things that kind of I hope I've left you with is that this is a pretty exciting time for those of us in nephrology. It's exciting because it looks like there's a ton of stuff that we now are going to be able to do in patients with CKD, and I'm not showing you a lot of this, ESRD, to prevent reduce cardiovascular disease, to slow progression. Many of these products are either on the market, the SGLT2s, or soon to be on the market, some of these other drugs as well. And so hopefully giving you some idea of kind of where we're going, what's new in nephrology, and how exciting we are as far as nephrology as a field, and what we're going to be able to do in the next 5 to 10 years. Thanks very much for coming this morning. I think I've left myself time for a few questions, if there are any questions. Yes, please.
As promised, you went quickly, so I'm not sure I saw this correctly. With respect to the ACE inhibitors,
Yes.
I think you showed that in all comers type 2 diabetics, roughly 10-12% hazard ratio reduction in cardiovascular events.
Yes.
But the first part you showed was what I would call subgroup analysis, and it appeared to me that those with the 20-ish% increase in, let me say 20% decrease in GFR had about a reciprocal increase in hazard ratio. So for that subgroup, it looked like it was essentially neutralizing outcomes.
I'm struggling a little bit with the question. And so because of the subgroup side of it. So what I tried to convey is that if you look at all comers, then a bump in creatinine is bad for you. On the other hand, kind of, whether you're if you get the bump in creatinine, you're better off being on an ACE inhibitor than not being on an ACE inhibitor. So bottom line is, yes, you get a bump in creatinine, but you should stay on the ACE inhibitor because compared to no ACE inhibitor, you're better off. Maybe we're done. Come, let's look at the slide together when we're done. Other questions, concerns, and especially anything you've heard different from me than you've heard from other kind of diabetologists or nephrologists? Yeah.
I was just curious about the HIFs and the cholesterol. What would be is there a thought of how they affect lipid metabolism?
I don't know the answer to that question. Not enough a cholesterologist to answer that one. Striking decreases. I thought what you were going to ask me, this is a due diligence answer. And the due diligence here is we have 10-year-old data that says in ESRD, if you treat people with ESRD with a statin, you see a 20, 30, 40% decrease in serum cholesterol, but no cardiovascular protection. And so in ESRD, statins are not helpful. That may be heresy, but it's true. And so this is CKD. And so remember I said that people with ESRD are the warriors. They made it to ESRD without dying of cardiovascular disease. This is kind of trying to deal with the other 15 million people with CKD. And I don't have an answer for you on that one. Please.
How pricey are these drugs? How pricey?
Thanks for asking that question. And so, the one class of drugs we have out there right now, and I skipped this, are the new drugs that lower serum potassium, patiromer and sodium cyclocryosilicate, CS9. And so these are drugs that in ESRD and CKD lower serum potassium. They work like a charm. They're all wonderful. $400 to $500 a month. And so my sense, don't quote me on this one, is that the drugs that we talked about today, other than the immunologics, are going to be $400 or $500 a month on top of everything. And so what we don't have yet is we don't have cost effectiveness data that says that it's worth it. And after that, kind of, we don't know who's going to pay for these things in CKD. ESRD, kind of, if you got it, Medicare's pretty good. In CKD, we've got issues. So there are all kind of issues with that. And so we'll see. Yeah.
In any of the game-changing drugs, was age a factor? Did they cut the study off at a certain age?
No. And so especially the SGLT2s don't look their age-related. They're CKD-related. GFR is under 30. We're still nervous about them. The endothelin receptor antagonists, the same issue. They look pretty good. All these drugs have been tested at all ages and look pretty good. The side effect, the other thing that's nice about the drugs that we've talked about today are drugs that the side effects kind of, you know what's coming with most of these drugs. By that I mean the major side effect of a lot of these drugs is potentially hypotension, rarely happens, edema, you can see it coming. It's not CNS toxicity, and it's not encephalopathy. And so kind of another reason to be excited about it, not that kind of hypotension or edema is good for you, don't get me wrong, but on the grand scheme of things, maybe a little easier to deal with than some encephalopathy, et cetera. Yes, sir, please.
I wonder why so many diseases are associated with inflammatory response. So when looking back at our evolution, is that something that was a response to infection or injury, and now it just non-specific response to anything that goes wrong? If that would be true, then using those drugs, would they increase the chances of neoplastic disease and would reduce the effectiveness of treatment or increase the chances of infection?
I mean, it's a great series of questions. Kind of the first one was, the more we look at many of these chronic disease, the more they look inflammatory mediated, be it heart disease or kidney disease, you know, or even diabetes at times. And so from an evolutionary perspective, I don't have a wise answer about why that should be. I think that what may happen from a individual standpoint is the inflammatory response is there to protect not only from infection, but from other external antibodies as well, and kind of it gets out of line with, for example, kidney disease that in some way regulates that response that we don't know yet. As far as the issue about long-term oncological kind of complications, on the grand scheme of misery, the drugs that we've talked about today, the renal kind of drugs have not been associated with that. The new drugs that are anti-inflammatory kind of have been associated with it in rheumatoid arthritis, chronic bowel disease, and stuff like that, as you might expect. But at least the non-immunologics in renal disease have not shown that so far. Long-winded answer that I don't think answered your question, because it's too good a question. Yes, please.
I just get on the ACE-ARB thing.
Yeah.
Did I get this right, that the actual hazard wasn't that great in that study? And so if you had somebody who you were having trouble controlling their blood pressure and you were sort of reaching the ends of medications, you might actually combine the two?
Yes. And so up until this study, that would be a no-no, because there were issues that the combo increased the hazard ratio. This study, which is the largest, and a couple other studies in the last year have shown the same thing. It may or may not be efficacious, but it's not going to hurt anybody. And so in general, we've not done that, only because we don't think the bang for the buck is enough compared to other additions. But if you're up against it and you got nothing else to do, so to speak, there's no reason not to. All right, thank you very much for coming out, and appreciate it.
Thank you so much.
Yeah, no, good.